Well, good afternoon and or good morning, depending on when you're listening to us. It is September 30th, 2024. My name is Jason Belton. I'm the Director of Emergency Preparedness for the California Association of Health Facilities. And hopefully you've landed at the right place. This is the Nursing Home Incident Command System virtual workshop presented by Los Angeles County EMS Agency through their hospital preparedness program. And so we're going to dive into an introduction to the Nursing Home Incident Command System. And and just as some housekeeping items, if you need CEs for this, you have to if you're listening to this live, there'll be you'll have to go into the CAF Learning Management System and answer the challenge questions for the session once it's over. If you're listening to this recorded on afterwards, after the fact, unfortunately, there's no CEs available if you participated. But the good news is the information will all still be the same. So that being said, everybody's going to be on mute during the presentation, but there's an opportunity to ask questions. And if you look up at the top, there's should be a little square box with a question mark in it. If you click that, it should open up the question and answer box. Go ahead and drop any questions you have in there. And I will, at the end of the presentation, we'll go back and answer some of the questions if I didn't resolve them during the presentation. So that being said, let's get started. Thanks very much for joining us. Well, got to figure out how to move the slides along, but here are some of my particulars. If you don't know, I've been with the California Association of Health Facilities for about 12 years now, since 2013. I direct the life safety programs, emergency preparedness, infection prevention and control to some extent, and the physical plant programs, as well as some Cal OSHA stuff as well. I manage 3 disaster grants, one with the state, one with LA County, which is contributing to this webinar, as well as Sacramento County. I sit on the American Healthcare Association's, or AHCA's, Emergency Preparedness and Life Safety Committee. I'm a California Coalition for Person-Centered Care board member, as well as a Hospital Building Safety board member with HCI/OSHPA. I'm the incident commander for our mutual aid program at Sacramento County. That's the SASMAP program. And hopefully we're going to be talking about doing a similar program like that here in Los Angeles County in probably beginning in 2025. In the middle of 2025 is when we should start talking about mutual aid as it relates to long-term care in the county of LA. I'm also the ESF8 Cal OES liaison. You'll hear what a liaison does in a little bit here. We'll talk about that role within the Incident Command System. And then I also work with the CDC and HHS federally if there are issues related to long-term care from a national sense where the CDC would be involved. Pandemic is a perfect example of that. And then prior to my time with CAF, I was a volunteer and paid on-call firefighter for Vacaville. I left fire service in 2009, but I'm still currently a CERT team member, and I volunteer with the Sacramento Fire Department currently. All right, so our objectives for today is to introduce folks to the Nursing Home Incident Command System, learn the roles and responsibilities within the Incident Command System. We'll talk about objective setting in the context of NHICS, since that's pretty important. That's a hallmark of where we start our operations. And then we'll talk about how to implement NHICS in your own facility and how to train your staff on NHICS. All right, just a little brief history. If you didn't know, Incident Command System is based on the kind of military hierarchy that's gone on forever. Well, maybe not forever, but for a long period of time, longer than ICS was a thing. In the 1970s, the California Fire Service, or multiple different fire departments within California, decided it would be good to create an overarching system that unified command structure. It provided common terminology. It provided us management by objective across different response agencies, and we needed to design something that was flexible and modular. And so An example is, when fires used to start, one fire department would respond and another fire department would respond. And those two agencies didn't have a central kind of communication point to say, we're taking this section of the fire, you take this section of the fire. And so there was a real lack of coordinated response to fires prior to this time. Now, since that time, not only has ICS kind of taken hold, but it's actually become the standard of practice for everybody that works in emergency services during disaster response and or emergency response. And so that includes law enforcement, firefighters, your public health agencies, schools, hospitals, and long-term care facilities. And so this has morphed itself into something that can be used and should be used to kind of oversee operations in emergencies or disasters across a multitude of settings. And we'll talk about why the system works and kind of how we can work within that system for our own purposes. Now, most of this is going to talk about best practices and things of that nature, but it is important to realize that the Center for Medicaid and Medicare Services, CMS, has a pretty substantial set of emergency preparedness requirements for long-term care facilities. And when I say long-term care, that's, in quotes. For CMS's purposes, that is skilled nursing and intermediate care facilities. Now, does it mean if you're an assisted living facility or if you have multiple levels of care, this only applies to your nursing home setting? No, it should apply to all settings, and we'll talk about why that's important. But for CMS's requirements, they require 4 individual components to be a part of your program. So you need an emergency operations plan, you need specific policies and procedures. So missing resident, evacuation, shelter in place, those are just some of the mandatory policies and procedures you'll need to have. Communication plan, how do we communicate with outside entities? What's a primary and alternate means of communicating with them? What are primary and alternate means of communicating with our staff? Things like that. And then at the end of all that, there's a training program that we train all staff on our emergency operations plan, and then we test that program. And that test is generally in the form of a exercise, either a functional full-scale exercise or a tabletop exercise. And we'll talk a little bit about what the difference between those two is in a minute. If you're using the CAF emergency operations plan template, all of our templates really indicate that people would use NHICS in the operation of their emergency operations plan. So if you have our template, you definitely, at least your policy says you're going to use NHICS. And how does NHICS help fit the new regulations? Well, provides staff assignments, succession planning, and the process to collaborate with our local response partners in unified command. All right, so what are we protecting ourselves for? Certainly, we have a number of different natural hazards that we could potentially be at risk for. We've got things like wildfire, which is a common one, an earthquake. We're all familiar with that, or maybe some folks haven't. They're young enough they haven't experienced Northridge or Loma Prieta or any of the other large earthquakes we've had in the recent past. Just know that those are a realistic thing, even if we haven't experienced one in the recent past. If you remember back in 2017, this was a unique one in my career. This is the first time I've ever had to experience this. Was Lake Oroville after a particularly wet year in 2017. The emergency spillway, which is a spillway that's designed to catch the overflow if the lake becomes too full. Well, that spillway failed, and then there was a second uncontrolled emergency spillway failure, where they thought there was potential for a significant loss of water out of the lake that would inundate Marysville and Yuba City, parts of Oroville, Live Oak and Gridley, some of the communities that are just south of Lake Oroville, all were forced to evacuate, about 200,000 people. So a lot of different things can happen in California. We're not immune to natural hazards, risks from natural hazards, but that's just a part of the story. We also have things like man-made hazards, active shooter and armed intruder. workplace violence in between staff or staff and resident. We also have domestic violence in the workplace where somebody's personal relationship has spilled over into operations at the nursing home. That's happened, gosh, it's happened very recently. And will continue to happen, unfortunately. And then missing resident is another one we've got to factor into our planning. Um, and then one we really don't talk about or don't think about is other man-made hazards like transportation and infrastructure challenges. I didn't put on here, but supply chain is another big one that we experienced during the pandemic. These are all potential hazards that could affect our ability to operate. So if you're keeping score at home and you do your hazard vulnerability assessment, which is a part of those CMS requirements, um, you'll need to factor in all these different kind of risk categories. If you use a form like the Kaiser HVA tool, it will lay out most of these risks for you. And I realize the Kaiser tool is specific to hospitals, but 95% of the categories in there apply universally across different settings. So don't let that stop you from utilizing that. Just either put zeros in for the things that aren't a hazard for you, or remove them altogether from the spreadsheet. But you will need to do this at some point. So why is that important? I think it's important to understand that in many instances, and most instances, we're going to be the first responders during disasters at our facilities. And there's generally not a ton of resources sitting around at a county or a city level waiting to be deployed to long-term care facilities when they suffer some kind of loss. Now, if it's an individual facility, one facility that has an issue, the county or the city may be more appropriately or may be able to access those resources to help you in a disaster much easier. But in a large scale event, like let's say an earthquake, if we have Northridge happen again, and it will happen at some point, maybe not in our lifetimes, but it will definitely happen, a large earthquake hitting the Los Angeles basin. In those instances, we are going to be the first responders because 911 is going to be kind of utilized to help people in the community that are at risk and need help. And so we really have to understand there's a finite limit to the resources that we have access to, and we have to understand how to be first responders for our residents. And I think the pandemic and other responses to disasters have really led me to the clarity that we are the experts on our residents. There is no other expertise that lies outside of our profession. When if you're evacuating a facility and Mr. Smith in 1A, is normally very talkative, but during this evacuation he's gone quiet or whatever the case is, you'll be able to recognize those changes of conditions that other folks won't be able to recognize, and that will help minimize our potential for transfer trauma if we have to do something like evacuate. So it's important to understand that not only do we know our residents, but we provide care to our residents different than what other people do. And I like to use the example of, we stood up all these alternate care sites during the pandemic, and we told them, these congregate settings, doesn't matter really where who's in the congregate setting, any congregate setting where you have, more than one person in a room, it's going to be very difficult to control the spread of a virus. And so we knew that. And so what we asked the community to do was, could we set up an alternate care site where people that were being discharged with active COVID who were still contagious, could they go to kind of a collection point that wasn't in the acute care hospital? So the acute care hospital would have space, but the alternate care site could take these folks until they were out of their contagious phase and then send them back to their originating facility, or if they were a new admit to a new facility. During that time, the government, both the state and the county, really kind of said, yes, we can do that. And there is a procedure to do that. They had kind of planned out locations and how they were going to support and get staff there and things like that. What ended up happening is that they restricted admittance to those alternate care sites, so much so that it really negated our ability to be able to use those sites. And so they didn't allow for feeding. They didn't want to do any feeding. They didn't want to do any transitioning out of bed. They didn't want to do any toileting. They didn't want people that had dementia. As a diagnosis. So all of those things really kind of negated our ability to access those resources. And that's why I said there's nobody outside of our profession or industry that really understands what it is we do. And so it's important to know that we're going to be their first responders, probably, and probably their primary responders, meaning that sustained operations during a disaster will generally be by our staff rather than outside staff. All right. And so when we think if we're going to be the ones as being the primary responders, and not just us, but our staff, is we have to understand how to react during a disaster or crisis and provide that leadership that's necessary. And on this slide, we can see some examples of where that leadership and that kind of understanding of how best to weigh risk and benefit and to determine what's best for our residents. And then we have some examples of how that's done poorly on the right-hand side. And so obviously most of you have heard of Sully Sullenberg, who landed that plane on the Hudson River. That was a fantastic example of the incident commander or the leader at that time making the best decision to protect life and health of his all the people in his charge. And so in that instance, he weighed the risk and benefits of doing specific activities and then said this was the least risky, though it was incredibly risky. It turned out fantastic. I think that had to do with his competency as a pilot as well, not just good decision making, but what are some of the reasons why we would fail to do that? And airline pilots are a great example of how to learn to manage emotion at a time of crisis. Really difficult to do because our brains have a subconscious need for normalcy. Airline pilots plan for failure. That's what they do. They practice that failure when they go get requalified or qualified on a type of aircraft. They train to fail. And we need to understand that in order for us to get to that point, we have to train and test our plans to fail. And so when we find those failure points, we can mitigate them or correct them. We also have an optimistic sense of bias. A lot of us do anyways. Not everybody's an optimist, but there's a fair number of folks that do have optimistic bias. And the best example I have of that is at the highest levels of government, we determined that the COVID-19 virus was not airborne until maybe a year into the actual response. And that was a clear, in my mind, a clear kind of indication of optimistic bias because all of the data indicated that it was primarily airborne, if not almost exclusively airborne. We didn't have any data that showed fomites were creating transmission risk. We didn't have any data to say that surgical masks were protective enough. Those are all issues with optimistic bias. And I think a part of it is people didn't really want to talk about an airborne virus because of what that means in terms of how we treat airborne versus transmission-based precautions. Some people are unable to comprehend the scope of the event, and certainly that has happened in the past. But some of these things can be corrected by addressing the last 4 bullet points, and that's we can create a culture of safety in our organization. It starts with the administration and leadership and ownership. But it needs to pervade through all of your staff, and we'll talk about some of how we can engage our staff and things like that as we talk about how we implement NHICS later on. But certainly, we can create a culture of safety we can do planning and we can do preparedness. We can do training and we can do practice in the form of exercises. And we're going to cover this part here, leadership. What does leadership look like in a disaster? What are the things that we must factor in when we make decisions during our response? And what are the principles that should guide our operations? And we'll talk about all of those. So the first phase of every unexpected event is chaos. Leadership is critical to setting the tone of calm, assessing the situation, and guiding the response. In incident command, we talk about operational periods, and we're going to cover that in depth in a little bit here. But we need to have decisions what to do now in that first immediate operational period. And we're talking about the first hour to 2 hours of the response. And then we'll talk about, kind of sustained operations during a response, because it doesn't just end at 1 hour. It goes on, and events drag on. The pandemic is a perfect example. We were activated in that event for multiple years. So hours, days, weeks is probably the common. And then in the case of a pandemic, you may have to go, multiple years in emergency management. Events do have the potential to go sideways, so we need to have a dynamic planning process where we're maintaining situational awareness of all of the conditions that could impact our operations, and then having that kind of feedback loop where we end our operational period and we talk to each other and see, are the tactics and strategies that we're doing, are they still working? And when we're talking about these planning processes, there's a specific thing within incident command called the incident action plan, and we're going to talk about that. But that's going to happen every time you have a new operational period, and then you'll adjust those objectives as new information comes in. The incident commander is the person that sets the overall objectives for the response and recovery. Once the incident commander identifies overall objectives, the IMT staff or the incident management team staff will develop strategies for each section. And so we're going to talk about who goes into the IMT staff, what people can fulfill that role, things like that, and what each role actually does. And then as the response evolves, needs and priorities can change. We talked about that, and leading to revisions of objectives and strategies. A perfect example would be, fire starts on, 5-10 miles away. You're monitoring the fire. You're currently sheltering in place. You've closed your fresh air intake, so you're not getting smoke pumped through the building. And then you're planning on just sheltering in place and making yourself available to the county or to your sister facilities or to your other long-term care partners. But you're going to monitor the conditions. And let's say the fire and the wind is all heading in your direction. And now the fire is a mile away or 2 miles away with no sign of abating. This would be the time when you're going to change your strategies and go, okay, we have to convert to evacuation at this point. And so that's an example of how you would monitor conditions, and the needs or priorities change, and you're going to have to change your objectives from sheltering in place to evacuating. All right, the 4 C's of all hazards planning, and this should go into all of our planning when we're talking about all hazards. And I mentioned that earlier. That's what CMS wants us to concentrate on, is all hazards. So we need systems that work with any type of hazard. Incident command system, I mentioned this earlier, but every response entity uses the same system to manage emergency or disaster response, and that's all hazards. It doesn't matter what the peril is. The same response is going to occur. In that 4 C's of all hazards planning, we'll touch on each one of these things, but we're really going to concentrate on command and control because that's what NHICS is, or ICS. In terms of collaboration and communication, these are the folks that we should be collaborating with and communicating with through our healthcare coalition. If you're in Los Angeles County, which I'm assuming most of you are, it's the healthcare coalition is a little bit different in our county in that the DRCs, or disaster resource centers, which are grouped at hospitals throughout the county, act as the healthcare coalition hub. So if you're not attending those meetings, you need to attend. That's a part of one of the CMS requirements is not necessarily to attend the coalition meetings, but to gather the material that's only produced by the Healthcare Coalition. And so one of those is that hazard vulnerability assessment that I mentioned. CMS requires us to do our own, but it also requires us to get the community HVA, and that is done through the Healthcare Coalition. They produce a global or joint kind of risk assessment, and then they'll pass that out to people, but they can only give you a community-based HVA if you have contributed with your own HVA. So the idea is you submit your risk, the dialysis center, the clinic, the community health center, the hospitals, and all of the other nursing homes, they all do this risk assessment, the hazard vulnerability assessment, and then they submit it to the DRC coordinator, who takes all that information and creates a community-based HVA, meaning that geographic area, meaning the resources that are available to you, those are all created by the Healthcare Coalition. The Healthcare Coalition also does multiple tabletop exercises, generally a year. They have access to good information. So these are the folks that we need to be collaborating with. Generally, there's a representative from CAF at the DRC meeting, so you'll have access to us and our staff. But you will also have access to the MOAC program, which is critical to understand how we access resources when our resources get expired during a disaster. All right, so how does this information communicated to? We mentioned communication. For us, we need primary and alternate means of all of the folks that we could potentially need assistance from in a disaster, as well as people that we need to notify, people like the ombudsman, our families, or licensing district office, HFID offices, depending on where they are, things like that. But in terms of how we access resources in a disaster, it's all done through that MOAC program. And so for us, now, if you're in assisted living, you got to close your ears because this is specific to skilled nursing and intermediate care facilities. So for us, the way it's supposed to work is an event happens, we use our resources, we use our vendor network, we use our corporate resources to help fulfill our own needs. And then the instance when those resources are expired and we need those resources in order to continue operations, to maintain continuity of care with our residents, then that has to be communicated through the MOAC program. And that is done through the MAC or Medical Alert Center. If you're a skilled nursing facility, there's a program called ReadyNet, ReddInet, ReadyNet, and you've probably seen communications from me about getting signed up to be on ReadyNet. ReadyNet is a computer program that has all the categories of care, like male, female, this is a short term, are they event resident, things like that, in terms of categories of care that we need when moved. So if you're in a disaster, theoretically, you would log into ReadyNet, you would answer any kind of service level poll saying, yes, I'm okay, or no, I'm not okay. And then in the instance where we're evacuating or moving people, there'll be a request to identify whether you have any open beds and what categories those open beds are in. And so ideally, the MOAC would take that information and either ask HFID to help our licensed folks to help move those residents, or they would try to do it. It would depend on the size of the event. Generally, if it's just a one-off event, they would be able to manage that. But if it's a large-scale event, they're probably going to deputize HFID and ask HFID to help do patient movement or resident movement through a disaster. The reason being is there's so many facilities within the county. We could outstrip the ability of the MOAC to manage that kind of program if 10 or 15 or 20 nursing homes are all impacted at the same time. But in any case, our interface is always through that field level where we're going to talk to the same kind of person. But those folks can draw resources from the local government, from the operational area, from the region, meaning a mutual aid region, or from the state itself. And then if it gets built really, really big, we can see federal resources as well, like we did during the pandemic. All right. The flow of information is supposed to go up and down, and the coordination and control is supposed to go up and down. So theoretically, if we're operating in incident command and all of these other jurisdictions are operating in incident command, that we should be able to work in unified command with each other and share a flow of information that goes from us to them and them to us. Now, am I we can do better at this. All of us can do better at this. The providers can do better at this, but the communities can do much better at this. And we saw during the pandemic, there was a lot of flow of information down to the facilities, but not a lot of flow of information up from the facilities to talk about feasibility or impact or how certain things would be handled. Like you say, okay, well, they have to be in a single room. You go, well, that doesn't exist in our settings. I'm sorry, it just doesn't. So yes, we hear what you say and we don't disagree, but we don't have the capacity of that. Well, our feedback to them for that information was capped. Nobody was hearing that information unless it came from me directly to one of the decision makers. And so we can do better and we should have done better. And hopefully, if we do this again, we have a framework for how to do it better the next time. Critical resources, that was part of the 4Cs. If you didn't know, staff and space are our two most critical resources. Staff members, obviously, we cannot operate without them. And space, we need a place to do our work. Our building is a shelter first, and if it quits functioning as a shelter, then we need to find another location that can operate as a shelter first. And so those are critical resources we need to have. We also need a place to do our work from, so a command center. It doesn't have to be something fancy like you see in a movie or a TV show. It can be at a nurse station. There are some things that you need. It could be remote. You could have a command center at a convention center if that's where you had to evacuate to, or you could do it at your home if you absolutely had to do it. There are a lot of different kind of creative solutions to doing virtual command that we all learned during the pandemic. And then we need subsistence needs for our residents, and that differs depending on who you ask, but CMS says food, water for resident staff and staff family members that would be until you would need to evacuate. And then for the state requirements, that's 7 days of food and water, and that's just for residents. It's not for staff. But I would like to say, pick a number, try to stick with that number, and consider staff, because if you're in a long-term situation, an earthquake or something like that, where we may be having community issues for a long period of time, 4 weeks, 6 weeks, or longer, it may be necessary for you to be able to offer a place where folks, if you need them to work, where they can feed their families at the same time, if we're going to ask them to be there for more than 12 hours at a time. And then transportation needs for our residents. Many of us have on-site transportation, but generally it's not enough to move the entire building and all our staff and all our equipment when we do evacuation. So we need to understand there's a limit to what we can do internally. How do we access a vendor network to get transportation during a disaster? Be realistic. If it's a large scale event and you have an agreement with a private ambulance provider or some kind of private transportation company, just know that transportation company is probably being utilized by multiple other entities, including the county itself. And so are they realistic? Can they be deployed during a large scale event? Be honest and open about that, because it can cause real issues on the back end. And I've heard of stories where, somebody couldn't access their traditional vendor network during a fire, and they called up a charter bus company to ask if they would come help them evacuate. And the building wasn't on fire. It was, let's put it this way, a normal evacuation, as normal as an evacuation could be, in terms of they had time to go. They had 5 or 6 hours before probably the risk was going to be even greater than it was. And so they called the charter bus company, asked the charter bus company, and the charter bus company said, absolutely, we'll be happy to come help you out. All I need is a $10,000 deposit on your credit card. And so what do you do at that point? Do you pay the $10,000 or do you roll the dice? And so it's understanding that if we don't line up the transportation before the disaster, um, then we're going to pay a premium for that on the back end. In the instance where we can access transportation at all, we're going to utilize the MOOC system to help identify transportation resources. And then, of course, in the case of a really, really bad disaster where the system is stretched and we don't have identified transportation, the 911 system will still work, but just know that if we call 911 and say, I'm a long-term care facility, or I'm an assisted living, or I'm a skilled facility, and I have 90 residents and I need to evacuate, they're going to send what they can, and it might not be the right resources for the residents. They may send us 15 or 20 ambulances, whereas we may only need 2 or 5 or something like that. Many people can be transported on a city bus with a wheelchair lift or things like that. And so when we do that, yes, the community will respond to our needs the best that they can, but just understand that when we do that, if we've not planned this out, we're now taking away those resources for the rest of the community, and those may be needed, and we want to be as self-sufficient as possible, but understand there's a limit to our self-sufficiency. And then other equipment and resources to meet the residents' unique needs, and so that's everything from bariatric wheelchairs and bariatric beds to oxygen concentrators and BiPAP and CPAP machines. It's walkers and wheelchairs and hearing aids and dentures. It's everything that folks need, to manage their care. All right, let's talk about the command and control, because this is really what we're here to discuss, is the incident command system or nursing home incident command system. As you can see on the Venn diagram here, everybody uses ICS and they use different versions of ICS. But the reason why we do that is that consistency, that interoperability that we're doing. When we fill out a Form 201, it's the same as a hospital or a fire department filling out a Form 201. And you'll see what that means in a second. I know it doesn't mean anything right now to you, but just hang on and we'll get to that. And then the picture on the left here is the incident management team, minus one position, and I'll show that in a second. But these are generally what's called the FLOP, meaning the general staff, the finance, logistics, operations, and planning, and then the command staff on the right-hand side of that diagram. That's a public information officer or liaison. It's a safety officer, and it should say medical director or specialist on that last bullet point. The liaison is actually wrapped up with the public information officer. Here's a better look at that. I apologize. I didn't even realize that graphic was wrong. I'll have to remove that slide. In any case, incident commander is at the top, and then we saw all of these, and then under the operations section, you should see resident services branch director and infrastructure branch director, and those roles both report to the operations section chief. And we're going to talk about what each one of these roles do. And you can see there's one off to the left on the top here. It's called scribe and runner. And those that's not a position that's in traditional ICS, but we found it would be helpful if you could. Now, you might not always have enough staff to be able to assign somebody as just a scribe or just a runner. But it is helpful to the planning section chief to have somebody help capture information that's being relayed during those incident action planning meetings and capturing that information if they're not able to document it. So I like to think that it's, it would help folks out, but it's up to you. It's not a necessary component of incident command. The reality is the only role here that needs to be activated for any emergency response is the incident commander. And then that incident commander will make a determination of what roles need to be activated based on the nature of the response. I would highly recommend that you have an identified incident commander on all shifts, 24 hours a day, 7 days a week. And those folks, no matter who they are, should have some form of incident command training. And even if it's just to watch videos like this, where we're going to have a couple hours to discuss, kind of the things that happen during disasters and how to operate those things. But more than anything, I think, your off hours incident commanders have to understand how to prioritize things in a disaster. An incident command really talks about we're going to preserve life and health over everything else. And so our actions and our objectives and our strategies and tactics will all relate on how we feel it's best to protect the life and health of our residents and staff. That's the overarching goal. And then once we've managed the protection of life and health, then we talk about stabilizing the event, making sure it doesn't get any worse, and then protecting our property to make sure we don't have a property loss, because sometimes that's going to be really difficult to recover from. And then we start thinking about things like liability and our reputational exposure, but those come way down the road, and our financial exposure, how much money it costs us to do certain things. Those are not the primary, or should not be the primary deciders of tactical direction. It should be based on that very first thing: life and health of the residents and staff above all else. And so, as long as your incident commanders can understand that, and they can do a risk benefit and say, well, transfer trauma is a real thing. We don't want to evacuate unless we actually have to. But if we have to, we want to do it as efficiently as possible. All right, so now let's talk about the general staff, and then we'll talk about what each person does. General staff is really 4 different positions, and these are all section chiefs. So if you go to CAL FIRE, when a large wildfire, they have these incident management teams, 6 of them across the state. In those 6 incident management teams, they have an operations section chief, a planning section chief, a logistics section chief, and a finance section chief. So it doesn't matter who you are. This is the general staff. And so when we say that interoperability, it means they're doing that. They have the same roles we have the same roles. And those folks do the same things. Now, their strategies and tactics and their objectives are going to be different for the OES department or CAL FIRE or something like that versus what our objectives are. But the same people are going to be reviewing those things, or the same roles are going to be reviewing the objectives and putting them into place. I mentioned this is called the command staff. These are assigned by the incident commander, and they report directly to the incident commander. That group is collectively called command staff. Same thing exists if you go to the incident management teams with CAL FIRE or any response entity. You're going to have an incident commander. You'll have a liaison or public information officer. You'll definitely have a safety officer. That's a big thing on the fire grounds. We need to protect responder safety. You need to consider that as well. And so during our operations, we need to have somebody assigned to monitor safety during the operations. And then we need a medical director or technical specialist. It doesn't have to be your actual medical director. It could be a medical specialist, meaning you're a director of nursing or you're infection preventionist, somebody with a clinical background that can help guide operations to our folks. All right, so what does the incident commander do? I mentioned we kind of have this priority kind of set, but a priority that we work by. And so we were going to go, we protect life and health above all else. Okay, what does that actually mean in practice? It means we set out objectives. And so the incident commander's first job is to activate the emergency operations plan and give those staff assignments, but then to set objectives for the initial response. And so the objective, let's say the building's on fire. The objective could be get out of the building as quickly as possible. And double check to make sure nobody's left behind. That could be a simple objective that you need to do immediately because life and health is at tremendous risk. But if you have a little more time to do, figure out your tactical direction, you'll sit down and have that incident action planning meeting, and the incident commander will come up with the initial objectives, after they have activated their staff. And then they're going to delegate kind of tasks depending on the role that each person is fulfilling. And we'll talk about what some of those tasks are. We have some checklists that kind of help guide you during the response in each of these operational periods, and we'll talk about where you can find those and what they're called. All right. Let's talk about the liaison and public information officer. I mentioned that I'm a liaison to Cal OES and CDC, and that just means that I communicate with those external partners in the event of a disaster. And so you would have somebody assigned to this role to communicate with external partners, and whether that's gathering information, whether it's getting on ReadyNet and submitting information. Um, Things like that. Creating messaging to go out to residents and staff and family and guardians, to the ombudsman, to licensing, and then develops any public information and messages. Now, this does not have to be a separate role. This can be something the incident commander does. But when you look at a large scale event, where especially something where you're evacuating, uh, you may you may not have the opportunity to assign somebody to this specific role. And so in that instance, it may be the IC or the incident commander that fulfills that role. But the one I want to caution you away from including is the safety officer. I really think it's important, and maybe it's my background as a firefighter, but having a constant view of safe operations for our staff and by proxy the residents, we can kind of minimize any potential risk factors during response to a disaster or an emergency. And so I would say that's the one role I want you to say we have to have somebody dedicated to this, even if it's somebody that's just walking around, almost like Firewatch or something, to review things and make sure they're being done right. And we'll talk about who is best to fill that role when we talk about the safety officer here in a second. But that's the only one I say you should have a dedicated person to. And then no, ensure safety, resident staff, any vendors that are on site, any volunteers that are on site, and any family or guardians that happen to be on site as well. They'll identify risks to the facility and then advise the IMT staff about any unsafe condition and recommend corrective action. And so in the instance, let's say we're evacuating because of a fire and a portion of the building is actually actively burning, we will want to move people away from that portion of the building and out into kind of a collection point. That would be something where we would prioritize doing evacuation from a specific point and in the facility while it was still safe to get those folks out. And so that would be an example of saying, okay, we're going to do our normal evacuation, triage, prioritize ambulatory folks first, prioritize people that can be discharged to go home, things like that. Well, if the building's actually on fire, we need to change that operation. We need to move people out of harm's way as quickly as possible and then address those other issues. So that would be something the safety officer would hopefully identify and say, look, we've got to change our tactics immediately. And let's stop. Let's just get people out of this area. That's an example of a role that the safety officer needs to fill. Now, the medical director does not, I mentioned this, doesn't have to be your actual medical director. And as a matter of fact, it's unlikely that your medical director would be on site unless they were actually in the building when the disaster happened. Usually they fulfill that role for multiple facilities, so they're not going to necessarily respond back to your facility in the instance of a disaster. That's not always the case, but I think generally, it'd be better to plan that they're not going to be there, and if they happen to be there, fantastic. But the medical director or medical specialist would oversee medical services, assist with medical management of residents and injured staff. They'd advise the incident commander and staff regarding medical, biological, or infectious agents, the ethical considerations we would need to consider, the hazmat implications potentially due to the incident. It's a lot. It might be a bit over. A director of nursing might not be qualified to do some of these things, but certainly, maybe having the ability to communicate with your medical director, especially on hazmat stuff or ethical stuff. I think we can access information, but you may not have it committed to memory. And so if you don't have the ability to access the internet or things like that, and do any quick research, it may be beneficial to have the ability to contact your medical director and involve them as well. All right, so I mentioned the operations section. These are the doers. These are the folks that are actually, carrying out all the tasks that the incident management team is planning for them. And they're overseen by the resident services branch and the infrastructure branch. And we'll talk about what each one of those folks do. So the infrastructure branch is generally making sure that the building envelope is still safe to be occupied. And so when I said our building is a shelter first, we have to understand it's a shelter first. And that means it, um, it if the ability to provide a shelter, a safe shelter, is taken away from us, then we have to cease operations and we have to move to evacuation. And that also means that where we evacuate to also has to be a shelter first, meaning it has to be prepared and ready for us to go. And if it's not, so that we can maintain continuity of care, like let's say you have to evacuate. I'll give you an example. During the Paradise fires, many of those facilities, because they had to get out while the fire was very close, did not have the opportunity to identify staging areas or areas to evacuate to. And many of them staged in the Kmart parking lot. And so that would be an example of them getting out because they had to, and then going to a staging area and waiting for further direction to get them to a place that could provide them continuity of care, meaning not to a public shelter, because of community shelters, they've got cots. They don't have medical beds. They don't have generally, accessible bathrooms. They're generally not set up to deal with our residents. And if we had to utilize one of those locations, it would be more to just stage there for final disposition to another nursing home or intermediate care facility or assisted living. Now, in the case of assisted living, you may have opportunity to be able to do that, but I would highly recommend maintaining some kind of contractual agreements with people to take your residents for a short period of time during the disaster, and then repatriate them back once the disaster has been rectified. So that's the infrastructure branch. So that person would need to verify wherever we're going is also safe, provided if it's a hospital or a nursing home. We're going to assume those other locations, they're licensed healthcare facilities, are prepared to deal with residents and patients. So, all right. So let's talk about the resident services branch director, because these are the folks that are going to be hands-on in the case of evacuation. They're going to be the ones wheeling folks out. They're going to be the ones preparing medical records. They're going to be ones preparing go bags, making sure the DME and personal effects are going with the residents, things like that. That's done under the resident services branch. So you can see how in an operation, especially in evacuation, this is going to be the folks where you need more staff to be able to assist with that. And so typically people in that branch would come from admissions, nursing, medical records, and then they'll also have to factor in caring for the psychosocial needs of the residents during the disaster. All right, let's talk about the logistics folks, because these are the folks that are the getters. So when we need more staff, we need more stuff, we need more space. That's the job of the logistics person, to identify where it is and to make that request to get those resources. They will ensure preservation of essential services and maintain facility supplies, equipment, transportation, and labor pool. And so that's a lot that falls on the logistics section, especially in something like a pandemic. It's going to be really hard, but that should be their role, is to consistently look to diversify our ability to maintain those facility supplies in perpetuity. That's for as long as we need it. That's essentially the logistics section's responsibility. And then under the finance section, these are the folks that track response costs and expenditures. So if we have the ability to have an insurance claim where we get reimbursed for some of our costs, this is important to track those costs and do costs over normal expenditures and things like that. The finance and administration would purchase supplies. They maintain detailed records. They're also going to oversee payroll and perform clerical tasks. In many instances where it's a large-scale event, you may need to convert to, kind of different schedule for your staff. In a lot of instances, depending on the facility, we've seen some facilities choose to go to a 12-hour shift rather than 3 8-hour shifts, 2 12-hour shifts. Um, and so the finance and administration will have to authorize those costs and track those overages to see if there may be a possibility for reimbursement on the back end. All right. The planning section chief, and this was kind of my role within the fire department, is we collect and report status information to get a common operating picture to help support incident objectives. In the instances where it's a wildfire, that's a very dynamic process. And especially if you're close to the ignition source of the fire, you have to be very well tuned into how soon or how quickly you need to activate. Just know that when generally you or I, in our personal lives, we get a notice from our community that there's something happening, no matter what alert system you use, it's generally a one size fits all approach. And so when they create an evacuation zone, if you're just on the outside of an evacuation zone, it does not mean that you should wait to evacuate. It means that you should monitor the conditions almost minute by minute. Because when they set up evacuation zones, they don't do it with the thought that there are folks within that evacuation zone need 6 hours to evacuate. And that's what most long-term care facilities will need in order to effectively evacuate without creating a condition which would exacerbate transfer trauma. And so that's not factored in when they set evacuation locations. And so just know if you're on the outside of that zone, that does not necessarily mean you're safe or that you shouldn't be preparing to evacuate. When we talk about ready, set, go in terms of evacuation planning, your notification is when that fire starts. That's your ready point. You're going to immediately monitor information. If you don't know how to gather information, you can go to the calfdisasterprep.com website. On the right-hand side, there's on the drop-down menu, there should be a map that says statewide situational awareness. Also, you can do HCAI, emergency operations. They have a map that lists out every skilled nursing facility in the state and hospital as well. And they put it in relationship to what natural disaster is actually occurring at that time. So if it's a fire, earthquake, flood, tsunami, things like that will be listed where the event is happening, where the event is moving to. Especially with a fire, we can look at the wind direction and we can look at the topography of where the fire is. And we can kind of predict the direction in which it's going. That's our key. We should be getting ready at that point. And if they call for evacuations outside of our area, but we're fairly close to the evacuation zone, that's when we should be getting set. We should be printing off face sheets and getting go bags ready to go. We should be talking to our transportation resources and asking how quickly can they get there. Those are examples of things that the planning section chief should be doing on a consistent and constant basis during the response. All right, well, we're not going to have a break because we're not doing this live. This is a virtual, and we're going to just push right through to so that hopefully we get done in time for questions and things like that. So in this snapshot, incident commander leads and manages the response. Operations, they're the doers, they do stuff. Planning, they collect information, they analyze, and they create the incident action plan. The logistics folks, they get stuff. The finance and administration, well, they pay for stuff. They pay for the stuff we get. So I mentioned these kind of checklists that we have created, and hopefully you're utilizing these. They are not a one-size-fits-all kind of approach. So we've put as much as we could in a kind of generic sense in the job action sheets, and they're position specific. So if you're an incident commander, you're going to have a job action sheet. If you're logistics chief, you're going to have a job action sheet. In any case, we have created kind of standard things that you would have to do in any response in these job action sheets, and they should be reviewed in the planning phase prior to activation. So you kind of get a flavor of what to do. My suggestion is pull this out when you do your drills and your exercises and do them in incident command. Immediately upon receiving an assignment at the onset of activation to ensure all tasks are considered and acted on if necessary. When I say it's they're fairly generic in nature. We do as much as we can to, think about the basics, but there may be site specific things that you need to add into your job action sheets. And I know that sounds like a lot of work, and it is. I'm not going to discount that, but it will help you to make a more robust plan that's more realistic to what activities you're going to take during the response. And then we task, excuse me, we task these job action sheets in what we call operational periods. And so the first response to any disaster is what we call the immediate response. Could be anywhere from 0 to the first 2 hours. And then intermediate response is that 2 to 12-hour period. And then extended response is anything past that greater than 12 hours. Now, we could have, operational periods that, every 24 hours, we got a new operational period. And, depending on the type of event, that may be necessary. In the instance where we had like the pandemic, where we had extended response just kind of go on for a long period of time until we got some new information, or we had to change the types of protection we did, or there was a new requirement of the mitigation plan, or whatever the case was where we had to change tactics. That would have been included, and we would have changed at the next operational period. We would have implemented those new changes. And so at some point during the pandemic, you should have been having, recurring meetings. And I'm not saying every 12 hours when the nature of the event is slow moving like that, but that may be necessary if you're in response to a fire or some kind of event that's changing frequently. All right, so I've mentioned the incident action planning process. This is kind of the meat and potatoes of what you do in incident command. And in order to do an incident action plan, you need to understand your individual facilities, policies, and direction. You'll need to be able to assess this situation. The incident commander will set those incident objectives, and I'm going to give you examples of what that looks like. That sounds very esoteric, but once I show you, it'll make a little more sense. You'll determine appropriate strategies to achieve those objectives. So what are the tasks we need to do to make it happen? We'll give tactical direction, ensure that it is followed, and provide necessary backup when tactical direction is initiated. All right, so those are all part of the incident action planning process. And we have a form that's kind of, we combined a bunch of different ICS forms into one form. And for those that are new to doing incident command, this is what I suggest. Rather than taking all the different forms and trying to fill that out and manage that, it's easier to do this one form where we've combined multiple things that you'll need onto one form. So if we look here at the form here, they're just blank information. You can call the incident whatever you want. In the case of a fire, you can call it the campfire that was from Paradise, or the Orville spillway failure, or whatever is the incident name. If it's a fire, generally they'll name the fire, and so you'll have information about that fairly quickly. And you can put that in as an incident name. The situation summary is just a narrative of what's happening at the current moment, and the operational period is today's date, or the date that it happens, and the time in which the operational period is going to be in effect. And so if you're in the first 2 hours, it would be from 0800 to 1000 hours. Or if you're in extended operations, it could be from 0800 to 0800 of the next day. And that happens quite frequently. So when you do this, you're going to gather information from the incident management team and summarize that situation. This will be what either the planning chief fills out this form, or the scribe, if you have a scribe. And you're going to record the objectives in the incident commander chooses, and the tasks that are assigned. And you'll see on the second page what that looks like. All right, so this is the back side of that form. We're going to list out our incident objectives, strategies and tactics, resources required, and who it's been assigned to. So when we think about objectives, we want to think about what are our desired outcomes. And we need to make them time-bound and accountable to make sure that we're achieving those. So evacuate nursing home within the next 2 hours. That's an objective. That's our desired outcome, safe evacuation. how do we accomplish those desired outcomes? Well, we're going to have to sign somebody to print off face sheets, somebody getting medical records, somebody getting DME, somebody getting transportation. These are all strategies and tactics that need to be listed out. Then what resources are going to be needed? Do we need a wheelchair bus? Do we need ambulances? Do we need, what do we need? And we're going to list them out there. And what role in incident command is it going to get assigned to? And at the end of the operational period, that person is going to come back and do, when we do our next incident action plan, they're going to say, yes, we're doing this, or no, we're not able to achieve this. So you have some kind of feedback loop to whether things are working. Here's an example of one that was done, and I think these are a little simplistic, but that gives you some kind of idea of what you're going to do. So we're going to activate our emergency operations plan. That would be an objective. What are some strategies and tactics? Even though these don't equate with the EOP, that would be more an evacuation, but print and package for transfer patient health records. That's an example of a strategy or tactic. Coordinate appropriate transportation for residents. I think we talked about most of these things. Activate our emergency communication plan and provide situational status report to the emergency response community or to LA County EMS. And then we'd update our facility operational status on, well, this says EM resource, but that's what we use in Sacramento. But in LA, it's ReadyNet. So we want to say, update facility operational status on ReadyNet, answer bed pull. That's a perfect kind of strategy and tactic. All right, and then the last part of the form has a health and safety briefing. We want to make sure that we identify any potential hazards and document those. Remove hazard, provide personal equipment, especially if there's fire. Make sure and folks are breathing smoke, heavy smoke. Get them respirators if we can while they're doing that, both residents and staff. Warn people of the hazard if a portion of the building is on fire or after an earthquake it's collapsed. We want to keep people out of that area. So that's something you're going to document here on this health and safety briefing. And then you can add things as an addendum to them if you need them, whether that be incident map, resident evacuation tracking, or anything like that, or emergency admit. So generally, we have a discussion when we're doing this in person, and we ask what role we think people would play and what they would be responsible for contributing to. But we're going to skip that. Hopefully, folks can put in the question box, answers to any of these questions. Especially the last one that's what I would be asking. If you're a part of a corporate entity, ask your corporate leadership to what does support look like during a disaster or an emergency? What roles would you be willing to fill? What resources could I reasonably expect to access through corporate support? And I would figure those out on the front end, not the back end. Oh, I got this in here twice. Oh, okay. All right, so incident response guides. Incident response guides are designed by incident management team position and includes fields that allow IMT members to add your initials when the actions are completed. So we're going to hand this checklist to people and say, oh, here's your guide for this operational period. You're going to go through all this, make sure all of these tasks are completed, and initial on the box and return that to me once they're complete. And we have these for all different kinds of hazards. If you've downloaded the NHICS tools, or if you have our emergency operations plan template, you'll see there's a ton of incident response guides in there. There's a lot that we have not created for. I don't think I have one for tsunami in there. I'm not sure I have one for volcano. There's some of the more less likely natural hazards. Doesn't mean they couldn't happen, but it's just that I have not created an incident response guide for them. But if you're interested in having us create something one-off like that, please put it in the chat, or you'll have my contact information at the end. You can email me and ask me to create something for you. Oh, I mentioned those NHICS forms. Here's a copy of what those NHICS forms look like. And these form numbers are consistent across all different response entities, so that 215A is a 215A no matter where you go. If you're in a hospital or if you're on at a major wildfire with CAL FIRE. They're going to do a 215, which is an incident action plan safety analysis. That's going to be done by everybody, and it's going to have that same form number. So while we say you can customize these forms for your own needs, you can put it on your letterhead, things like that if you want to. What we just say is don't change the form numbers because they're consistent across all these different settings, and it allows us to be interoperable with those different agencies. All right, so what does this look like in practice? Well, let's say the emergency event occurs. The incident commander would activate the emergency operations plan. They would assign staff roles and stand up the command center. And that's a fancy way of just saying that they're going to identify where the command center is and say we're going to operate from this location until further notice. And then incident commander will decide goals and objectives of the response. Generally, I like to think after they've assigned staff roles and they've had discussion with some of their IMT staff, especially planning, and then they'll brief the general staff on the response. I think, I like to include them after, especially as I'm setting goals and objectives. And then this is all within that first 2 hours. The planning chief will establish a briefing schedule, meaning when we're going to come back and review operations to see if we're on the right track. They'll work with PIO and ops to get intelligence. Operations chief, the doers, they're going to create or identify just-in-time training for any staff to help them guide the response. Many people, if they've not been involved in an evacuation exercise, they may not know what goes into a go bag or what should go into a go bag. And so, you'll have to do some just-in-time training to remind them of the elements that you need, that they will need to get for each resident when they're doing their go bags. And then identify key tasks for continuity of care. What are the things that need to happen so that we minimize the ability or the potential for transfer trauma. And then the logistics chief will identify resource needs, distribution of PPE, things of that nature. And the finance would work with logistics for supplies and work with ops to address staffing, especially if we need registry or some kind of outside source for staffing, but also to do staff recall and things like that. You may have your liaison work on that, or at least identify, maybe make the calls where the finance would identify who they should call for staff callback. The medical director or medical specialist would assess resident conditions and report that to the incident commander. And at the end of this operational period, the incident commander would regroup with the incident management team and then have a discussion to see if our tactics and strategies are working. Are there things we need to add or adapt to, things of that nature. And then we get into the intermediate response, and you'll see from this intermediate response, it's a lot of it is sustained operations of what we were doing in the first 2 hours. And we'll have to add some new conditions in because resident conditions could change. And so we need to have a constant process to assess resident conditions. We need to make sure continued care of residents is done by that resident services branch. The infrastructure branch may add additional cleaning or maintenance under direction from the operations branch chief. And then the logistics chief would monitor staffing levels and staff health, activate emergency staffing policies and procedures. Incident commander would contact and coordinate with EMS and CDPH, or for us, that's HFID, and work with the PAO to contact resident families. And then that finance person is going to track staff hours and expenditures and work with planning and logistics to pay for any ongoing needs. And then the ongoing response is 12 hours or longer. And so this could go on in perpetuity, theoretically, for as long as the event goes on. But much of this is sustainment and being resupplied. And a lot of times, the logistics is going to have to, let's say you're operating on generator power and you've been operating on generator for 48 hours. At some point, you're going to need to be refueled unless you're looking at being evacuated. And so that would be something we would want to restock and make sure we're monitoring those needs. And the infrastructure branch, some of the other things they may have to do is make sure there's proper disposal of hazardous waste or things like that. And then at the end of that, the incident commander, or at some point during that response, could potentially activate your business continuity plans or business continuity of operations plans or continuity of operations plans, depending on what you call it. But just think about these are all the systems that we need in order for our facility to operate. They may not impact patient care necessarily, but they impact our ability to operate. And if we can't operate certain things, that will eventually impact our ability to provide care. And so, in the instance, where we have a generator and we're on generator power for a sustained period of time, that's activating that business continuity plan to identify, what are the resources available to help us if our generator fails or we need to be refueled. All right, I mentioned the All Hazards Incident Planning Guide. This is an all hazards approach to emergency management. It calls for nursing home to work toward hazard prevention while at the same time preparing for emergencies. It may be customized to your needs, but we've created these all hazard incident planning guides. It's used for planning and discussion. You're going to have unique needs that your facility will need to address, things like elopement or things like developmental disabilities or dementia or bariatric or ventilator care. There's a number of different unique needs that you may run into that we'll need to plan for. We organize those into 4 phases of emergency management, meaning mitigation, how do we reduce the risk? Preparedness, how do we respond if the risk happens? And how do we recover at the back end after the event happens? All right. I like to throw this in there, and people who have heard me speak have heard me belabor the benefits of drills and exercises. I just say that, in order to get good at things, we have to practice. And many of your staff are learn things through different manners. Some of them are tactile learners, some of them are auditory learners, some of them are visual learners. I'm a tactile learner. I learn by doing. And so it helps me to do that. I also coach youth soccer, and for them, it's very much you show them and they can replicate it versus I can tell them how to do something and it doesn't actually have as much effect versus showing them something. So we like to say, I know CMS has a requirement to exercise our plan twice a year. I don't think that's enough. I think in order for us to be good at what we do, everybody on every shift at some point needs to practice what they would do in a disaster. And that includes folks on the night shift. And so I think more exercises are better, not just because we have to, but because it will lead to better response during a disaster. I've had somebody tell me that during a disaster, we always fall back to our lowest level of training. And if you've never been trained on these operations, even once or twice will help. It will frame things because it will give people an understanding of how it looks in practice, and it's different than what you envision in your brain. There will be snafus when you do certain things, and you want to get that wrong during practice, not during the actual game or during the actual event. So once we do exercises, we need to have kind of a review process that takes us from the practice we just did to fixing any of the issues that we identified during the practice. And so we call that an after action review. When we do our after action review, we want to lead with questions and not answers. We don't want to give answers to the questions. We want people to answer those. We want to engage in dialogue and debate in a no fault environment, meaning it's okay to get it wrong here because this is where we want to get it wrong. Because if we get it wrong and everybody sees that's not the right way to do it, then we'll have collective wisdom amongst everybody. And then we'll conduct those autopsies without blame. Like I said, this is no fault. We're all trying to get better. And that's the whole point of the exercise. And revise your plan accordingly. That's the feedback loop and say, okay, well, we need to address A, B, and C. We're going to assign those changes to a specific person. and we're going to say you're going to have 60 days to implement this change or revise these plans, uh, and then we'll review that at the end. All right, so how do we implement NHICS? We need realistic plans. We need training on what to do, easy to follow guides and checklists. We need to exercise and drill those things, and we need to do it in the form of incident command system. So I've talked about this training and exercise. It needs to be done in incident command, especially if you're using a CAF EOP template, because your own plan says that you're going to utilize NHICS. And so that being said, if you don't utilize NHICS and something happens and your own plan said you were going to utilize it and you didn't, and that lack of leadership led to a poor outcome during a disaster, you are now at risk for a multitude of different things, not just kind of liability exposure for the building, but in certain instances it could be criminal exposure or something like that. So we definitely want to make sure that we are using this when we do our drills, so that we know how to do it, at least a framework for how to do it. Identify the incident commander, have them wear the vest, have them assign the task, have them open up the command center and provide tactical direction to people. That's really important, and capture that in your incident action plan. And I promise you, your insurance company, your liability company, and the regulators who oversee our operations will be very impressed with your ability to operate during a disaster. All right. I don't know about 10 easy steps, but we're going to give you 10 steps we can implement nursing home incident command system. We need a planning work group. We'll review the material, make sure it's necessary, make sure it's applicable to our operations. And if we have any changes, we'll establish an approval process for those changes and get them implemented. We'll set a work schedule for reviewing these things. We'll consider developing an implementation training program with other nursing homes. I would say if you're a corporate entity, you should ask your corporate folks, hey man, can we get all the administrators, all the directors of nursing, and all the maintenance directors, and the people that would be involved with the response to and leadership during these events, can we all get them to do one standardized training for incident command? If you do that, I'm happy to come to you and do that training on site if you want, but you got to bring everybody to one location. I think if we do that, we will see vast improvements in our performances by having this standardization across our own corporate entity, as well as being able to provide mutual aid to our fellow providers. Then invite public safety, if you can, or public health, or EMS, or emergency management officials to participate as appropriate. And that includes maybe talking to the folks from the DRC to ask them to come, maybe review your operations or sit in on an exercise. Whoa, what a blessing that would be if you could talk to one of your DRC coordinators and say, hey, listen, I would love to do a functional exercise. I don't want to involve everybody, but I'd like to get my staff moving, and I would love to have you come participate and be an observer and an evaluator and help give us feedback on our operations. And these folks are practiced. They have mass casualty incidents all the time. They have emergencies all the time. And while they're subject to disasters similar to us, they take all the people from disasters. So in terms of having expertise, they're a great person to start with. And even though it's not listed on there, I would say I would talk to my DRC coordinator and bug them to ask them to come participate in an exercise at my facility. Now, I realize they have an actual job, and more of it would be more for their own edification and learning, so that they can help support your operations. But I really think that would be a great one. Determine your IMT chart. Who's going to fulfill which roles? I realize that a specific person is not going to be available when an emergency strikes, or you may get lucky, but emergencies happen on the weekends. They happen at night. They happen all over the place in terms of when they happen. And it'd be really difficult to say you have one incident commander for your facility. You need to have somebody on site at all times that is responsible for making decisions. And that includes up to and including evacuation, anything that would encumber you or put your residents at risk. We need somebody in that leadership position all the time. So we're going to select multiple people for each position, especially the incident commander, and then limit the number of times a specific person can be listed. I like to say, I think what may be easier, it may not be the, the, the very best of the best, but it's probably more consistent if you determine a role and say charge nurse at night is always going to be the incident commander, but it's important to let that person know you're going to be the incident commander. If anything happens between 11 a.m. and 5 a.m. or 6 a.m. before anybody else gets here, you are in charge. That means you're responsible for the life and health of all the residents and all the staff. I know it's a heavy lift, but they have to understand that so that they're empowered to make decisions that they feel are best for residents and staff. And we use that same kind of priority, life and health first. So hopefully that makes sense, that we can identify that. And I realize if you want to just do it and say administrator while on duty is the incident commander, when not on duty, it would fall back to this person and fall back to this role and this role. Those are examples. So we talked about the job action sheets. We're going to pull these out and make sure they're consistent with our facilities policies and procedures. Make sure that we make any changes that are necessary, but like I said, don't change the forms. Once any adjustments to the job action sheet are completed, we're going to immediately include those in the emergency operations plan. If you're using our template at the front of the emergency operations plan, there's a kind of a guide that says where each tag is located in the addressed in the plan. In the plan for annual updates, you're going to want to include this and say, yes, I have completed my annual updates, and these are what they were. I would recommend having job action sheets and all of the NHICS forms in multiple locations, meaning a hard copy in case no power and no internet. Or have them on a mobile device. Scan your emergency operations plan in a PDF, and then send that PDF to yourself and to all your incident management team, and make sure that they have that PDF on their phone or some kind of mobile device, and download it so that it doesn't matter if there's power in the building. It doesn't matter if there's internet. They have a copy of the PDF on their device, and so you'll have access to all your policies and procedures and all your job action sheets if necessary. That's worst case scenario. You can't access these things. That's a great place to have them. And then I would put job action sheets into the pocket of every NHICS command vest based on the roles that they're going to play. All right, we want to review those forms, make limited changes, add any forms you feel may be needed, based on your policies and procedures, and publish that and share that in the final NHICS. And like I said, these forms are standardized. Use only the forms you need. You don't need to use all of them. Use throughout the life of an evacuation, and it's okay to customize them, but retain the form number. And here's kind of what one looks like for the hospital incident command system. Their IAP cover sheet, meaning everything will be included with their IAP here. And this is a copy of another copy of the briefing. So here, I wanted to include this because folks, a lot of times they go, or they came from a hospital setting, or they came from another setting, and they go, like, I'm familiar with incident command. This doesn't look like it's all of the roles. And you're right, it's not all of the roles. And if you look at an ICS chart for the community, like if you go to LA County OES, they're going to have an incident management team that's huge. You're going to see all these different sections. You're going to be like, what the heck? The reality is all these roles have to get done. And the hospital, they've got a lot more staff than we do, so they can assign specific people to each one of these roles. That doesn't mean that the work is not going to get done. It just means that we have less people. And so these roles or these tasks and that are traditionally assigned to each one of these roles would be rolled into the section chief in many instances. And so that's that section chief is going to have some staff work for them. That's the roles they're going to provide. But it may be where you only have 4 or 5 people that can perform these leadership roles, and everybody else is working on operations. Especially if you're doing evacuation, it's all hands on deck for that particular event. And here's a copy of a completed incident action plan for a hospital, and you can see it's very basic. Identify an affected area that's been contaminated by a gray water pipe break. Identify any safety issues to patients or employees. I think that should be alert staff members, not Albert staff members of the situation. And then activate the hospital incident management team. So that is their first operational period from this gray water pipe break. And they activated their NHICS during this. And you may not even consider this as an emergency, but it's definitely, you should be activating your emergency operation plan, your business continuity plan, because you want to get restoration company in there quickly. Those things are examples of how you would do this. And we like to overcomplicate things. It has to be just a quick, down and dirty way to get things started. And then some of the factors we'd want to consider: has a gray water event affected patient care and safety? Do patients have to be transferred to a different unit or wing? Can we stop the flow of gray water to prevent future flooding? In any case, these are examples of different things. I like to include that because people think the hospitals are doing some crazy complex thing, and I go, no, it's the same thing. They just got a few more people to do it, and they have more practice at operating under this condition. In our NHICS guides, we have a glossary with a quick reference guide for key terms, and that's arranged alphabetically and includes all the acronyms. I know we're acronym heavy in emergency management, and that will help your staff out kind of determine what those things are. So we talked about reviewing the NHICS forms, place the final documents in wherever you have your command center, maintaining electronic and hard copies, and keep forms current with periodic reviews. The facility resource directory, definitely that's a part of, hopefully you're using this for your business continuity plan, but something like this where you keep track of all the vendors that you would need to service things like your plumbing and your HVAC and your electrician and, things of that, your roofer, things of that nature. All people you would want in your Rolodex in the case of an emergency, especially because we want to stay sheltered as long as we possibly can. And so if we can bring services to us, we want to have those resources listed out in that resource directory. In terms of reviewing the incident response guides and all hazards planning guides, study the results of your HVA. Make sure the all hazards incident planning guide meets those needs. If there's not a hazard that we have included in there, you'll make sure that you want to add that. Review the incident response guides and modify them if needed, and please place revised materials where they can be accessed by different folks. And then we want to develop an activation kit. And this could be, I've seen, folks have a trailer outside with all of their emergency stuff in it. I've seen other folks have like a cart they could wheel around, not like a med cart, but similar in size that has all its equipment in it. But we want to include this stuff. We want an incident management team chart, whether that's on a whiteboard somewhere permanently mounted, or a whiteboard that is portable that we can take and have people look at, so that the people in downstream from the command staff can be able to see who to go to for specific things. We need color-coded vests that indicate the incident management team role, especially the incident commander should absolutely have a white vest on. If you see incident command vests that are not white, don't buy them. Buy the ones that the incident commanders in a white vest. When you interface with the outside response community, especially in person, if you're wearing a white IC vest, whoever that responder is, when they come to meet you, will immediately think you're already in incident command, and I need to unify with your command structure. And you say, look, I've got a liaison. Do you want my liaison out here? Here's what's going on. How can you help me with my role? Those are the things. It's important to know that you are responsible for the operations of your facility until those residents are in another like facility. In other words, if you evacuate and you go to the convention center, you're still the incident commander for every single resident, making sure that all your staff and all your residents are safe in that spot. And you're overseeing operations to get them to the final destination. So we need, for CMS purposes, we need to make sure that we maintain that continuity of care. And and so that's important to have the incident commander vest on, because you will be providing the response community with tactical direction rather than them telling you what to do without having an understanding of the folks that you serve or the conditions that may exacerbate their health problems. So only you have that expertise. And so it's very important for you to communicate that and be seen as the leader from the response community. And then we'll want to print off job action sheets for each position and put those job action sheets in the vest so they have them ready to go. We need NHICS forms at our command center. We need other tools like radios, directories, paper pens, other ways of getting hold of folks. If you've got an 800 megahertz radio, you've got walkie-talkies, things of that nature. You will place these in a bag or a box somewhere in a secure location. And then, pull these activation kits out and test them frequently. Make sure that they haven't degraded while they've been in storage. Identify where you're going to have your command center. Ideally, it's going to be large enough to accommodate everybody. It will be accessible, meaning if you have somebody in a wheelchair, they'll be able to access the space. It's safe, it's secure. When I say safe, it means it needs to have things like emergency lighting. If we're on generator power, we need to have light 24 hours a day. It needs to be secure, away from danger, so that folks have the ability to do their work. And then we need adequate access to computers, phones, the NHICS material, all the stuff that we have talked about. And as a best practice, we can have food and bathrooms close by. That will help your staff get through this. Necessary technologies for the command center. We talk about phones and computers. But radios that we can communicate with the outside entity. If you got a ham radio, that would be an example. Fax machine, we don't traditionally use those anymore, but we definitely need a printer probably, unless you've pre-printed these things off. You can do, a fillable PDF for some of your NHICS forms, and that may be easier for you to type that stuff in, but just know that there is a risk that you might not be able to print off those things if the power goes out, or if the printer's not connected to a red plug, things like that. All right, all technologies should be regularly tested, especially with printers and computers and radios. If you're not using them on a frequent basis, they need to be included in your regular kind of preventative maintenance or inspection testing and maintenance for your maintenance staff to pull them out and do that, especially the printer. If you've got a printer that's only dedicated to doing just this, that ink is going to dry really quickly. You're going to lose the ability to print things pretty quickly if you're not addressing that. Most of the time, you're going to use a printer you're already using in regular operations, so that's fine. But just know that we need to plan for making sure these work on a consistent basis. And then once we've done that, we talked about doing individual and team training. CMS has a requirement, to train all new staff. So when we onboard staff, we need to talk to them about emergency operations. I think I would concentrate really heavily on the roles that they're going to play in a disaster, especially CNAs or line staff that are going to be hands-on with the residents, and really concentrate on evacuation and what goes into supporting evacuation. That's the most traumatic thing you'll do in a disaster. It's really, really difficult, especially if you have to do it quickly. We can just ask the folks from Paradise, from the campfire. Incredibly difficult to do. And so I would concentrate on that when we onboard folks and really talk to them about making sure that they understand that if we cease operations and we have to evacuate, their role with the provider stays. It's just that the location of where they provide that care is now going to be a new location, and they have to be prepared to go with evacuees until they're released. And so that means going to another facility or to a hospital or to a surge location where they're going to maintain that continuity of care until they're relieved. And so that's an important thing we want to communicate right up front with everybody when we onboard them. And then each annual year, we need to do some kind of training. And this is outside of the exercise requirements. This is just a training requirements, but those are the things I would concentrate on. And then of course, using exercises as a training tool. I think that tactile, that kind of hands-on learning cannot be replicated through book learning. I just don't. Maybe a video, people are visually aware and we can watch somebody doing something. We may be able to then put that into practice, but it really helps to train people and have everybody participate in those exercises. And so since, staff need to maintain care while you're doing the exercise, that's why we would recommend, if you do an exercise during the day, don't impact your daytime staff. Call in your nighttime staff for your NOC shift. Pay them overtime to participate in the exercise, and that will pay dividends down the road. And we like to talk about return on investment. I promise you, a prepared staff will exponentially pay for itself during a disaster. There are tremendous opportunities for us to make financial mistakes during a disaster that could compromise our ability to even come back and be functional. And so having a good prepared staff definitely has benefits on the back end in terms of financial return on investment. And then use the NHICS guidebooks and training modules. There's training modules available for free. So if your DSD wants to incorporate that and wants to use training modules, that we have those available on the website. And I'll show you where that's located at the end of the presentation here. All right, when we do our exercise, we're going to have an exercise committee and a chairperson for that committee. It should be probably the same work group you did for implementing NHICS. I would consult my HBA and take the risks that are most likely to lead to evacuation, and that's what I would plan for. I promise you that, after doing this for a while, I've seen people, struggle through multiple things, but the biggest struggle we've seen is emergent evacuations that need to happen within a very short period of time. So I would concentrate on risks that would lead to evacuation. So if you got fire, you got earthquake, you got flood, you've got all these things, you can simulate any of those kind of events to drive the exercise play. And then establish exercise objectives. Do it just like you would, during a response. Pull out that incident action plan and use that to document information. All right, consider a disaster drill first, walk before you run. You can incorporate NHICS forms, or you should incorporate NHICS forms. You should have an evaluation strategy. So somebody that reviews the actual exercise, not the person conducting the exercise, but somebody that's a third party kind of standing away. We call them evaluators. And that evaluator would just review, just watch what's happening, and then take notes and make sure that folks are going to meet the needs. So we'll need to identify somebody that can be an evaluator, and we'll give them some specific forms in which to review the activities. Then we'll conduct that drill and exercise while they're evaluating it. And then at the end of that, we'll have a hot wash or a debrief where we'll all come back together, everybody that participated, the evaluators, the controllers, meaning the person that does the exercise, and the players, meaning the people that actually do the work during the exercise. Everybody's going to come back together and compare notes. And we're going to talk about things that went well and things didn't go so well. And the things that didn't go so well are going to be a part of our after action report and improvement plan. And we're going to identify a multitude of things. It could be, a couple different things. It could be 10 different things. I would say it's probably best practice to identify three improvement plan items, give them a time sensitive improvement, when it's going to happen, when this improvement plan is going to happen by, and assign it to a specific staff member and make that a part of one of their responsibilities. Identify needed revisions to your facility's EOP based on that after action report. Ensure those changes are made consistently across all materials. If you've discovered, gosh, we don't have the right phone number for this person, or this is This didn't even mention, printing off face sheets. Whatever the case is, we want to make sure that makes it into our emergency operations plan. And then we want to discuss these um, at meetings and trainings, stand-up meetings, um, and get the word out. There's no reason why we can't have more discussions than we currently have in our facility as it relates to planning for and responding to disasters. So I mentioned that you'd have the ability to contact me. So that's me, Jason Belden at CAF.org, or Dr. Mary Story at CAF.org. Both of us represent the disaster preparedness program for CAF. We have a website that's free for anybody that wants to download or utilize any of the material. Some training programs are also on there as well. So if you go to the drop-down menu on the right-hand side where it says resources, if you look down at the bottom, you'll see videos. We've got a number of things in there, from industrial hygiene to best practices during wildfire, how to protect yourself from smoke, things like that. So there's a bunch of free trainings on there. And then we used to have an app, and I'm sorry, I should have removed that. Our service provider, where we had this disaster app that we provided for free to everybody, that company is no longer in business anymore, so they're not going to be hosting our app. We're actively looking for another app provider, but they're very expensive, unfortunately. And so I at the moment, I don't have the funds to be able to pay for that. And then the NHICS guidebook and toolkits. Those are available, as well as the training modules, and that's at that location at the bottom there. So hopefully you learned something new here. Don't hesitate to reach out to myself or to Mary if you have any questions. We'd be happy to answer those. We are at either generally there's a gal named Tamiza Teja. Tamiza's at every DRC meeting, so I mentioned those DRC meetings. I highly encourage you to be connected with that. If you don't know who your DRC is, if you've moved to a new building and you're like, I don't know what the closest DRC hospital is to me, give me a call or send me an email and I'll connect you. Let me know where your building is. We'll find the DRC and we'll connect you with the DRC coordinator so you can get integrated with those folks. That being said, it's been a pleasure relaying this information to you. Hopefully you gathered some information from here, and let's go to the question section here and see what we've got here. All right, you guys are a quiet bunch. No chat, no questions. Holy smokes. Okay. All right. Well, I'll give it another minute or so. Let folks join, and hopefully you found this informative. I'm not sure it was entertaining, but hopefully it's informative for you. In any case, it's been my pleasure. I continue to look forward to working for you and for the long-term care providers in Los Angeles County. Don't hesitate to reach out to me with questions about emergency preparedness or life safety in the long-term care setting. And with that, we're going to sign off and say we had a wonderful time. Thanks very much, and we'll talk to you soon.